So, good evening, ladies and gentlemen, dear colleagues. It's our pleasure to invite you this evening to a great mini-symposium about new developments about medical devices in COPD. It's my pleasure and privilege together with Peter Wegstra from Groningen to chair this very interesting symposium. This should bring together the latest in evidence, but also the latest in clinical practice. And we want to have interactive discussion, especially at the end with the panel, that you take something home, what we do with the evidence in our everyday clinical work. And I'd like to introduce first, as the first speaker, Nick Hart, who's going to tell you first that he's a Chelsea fan because Chelsea won the cup last year. Since then, he started talking about soccer again. And he's not only won the cup with his team, but he accomplished last year together with his team one of the most important studies in the field of NIV and COPD. And Nick, we're happy to have you here and hear about the latest analysis that you've done with the trial.
Holger, Peter, thank you. And thank you again for allowing us to talk. And I can say I could stand at this podium and I always feel excited when I look at this data. I feel excited because, in fact, this could help our patients, our severely ill COPD patients. So it's really important. Some of you would have seen some of this data, but some of this data is actually brand new because we only received it last week. So this is really exciting. We've got the intention to treat data. We published that in JAMA. But what we really are now focusing on is the per protocol data and the health economic data, which is going to support us by driving this treatment into clinical practice. Yeah, you can't do anything without having a few conflicts, but luckily enough, I seem to be conflicted with everybody, so I don't have a conflict. So this was published. This is the intention to treat analysis. It was published in JAMA. It was published at the ATS session. It was a joint JAMA New England Journal session. It had a very, very big impact in terms of audience participation. And Patrick Murphy, who led the trial, presented a brilliant, gave a brilliant presentation when he did that at the American Thoracic Society. But this is where we are. When I talk about severely sick COPD patients, and I talk about those patients receiving acute non-invasive ventilation for acidotic hypercapnic respiratory failure, nobody would argue with me that acute non-invasive ventilation is effective. And in fact, you need to only treat 8 patients to stop 1 death. You need to treat 5 patients to reduce 1 intubation. So this is brilliant. This is what we have changed our look on acute exacerbations of COPD. However, these guys have a high mortality and a significant mortality at 12 months. After the exacerbation of COPD, if your CO2 normalizes post-exacerbation when you've been very sick, requiring non-invasive ventilation, you will have the same outcome as a eukapnic exacerbation. However, if your carbon dioxide remains high, you have persisting hypercapnia and chronic respiratory failure, then you're going to have a poor outcome. The poor outcome will be readmission and death of the patient. Now, this was the target of the trial. We wanted a target population of patients who we felt would respond. We had done lots of physiological science to understand which patients would respond in terms of application of non-invasive ventilation. But we wanted to know whether home oxygen therapy and home mechanical ventilation could treat nocturnal hyperventilation and improve outcome. And we took admission-free survival. I'm just going to explain that. Admission-free survival means time to readmission or death. It's an event, and that's what we wanted to try and reduce. And these were all after an exacerbation of COPD. Multi-center, randomized control trial, all the data was held centrally, so we had no access to the data at all. We were just collecting data, putting it in a repository, and then at the end the data is analysed. This is the highest level of science you can use in clinical trials. The patients were coming in, they got acute NIV. At 2 to 4 weeks, if the carbon dioxide level was greater than 7 kilopascals or 50 millimeters of mercury, they could be randomized to home oxygen therapy or home oxygen therapy and home mechanical ventilation. We had the right target population, we thought. They had a high likelihood of an event, death or readmission. We had a treatment of using high-pressure non-invasive ventilation. We knew we could drive down carbon dioxide by using this strategy, and so this was the most important and increased the likelihood of having a treatment effect. We took the standard control group in terms of home oxygen treatment, and we had a composite endpoint, time from randomization to readmission or death. So we had severe COPD patients. They'd all had a life-threatening exacerbation requiring acute non-invasive ventilation. We saw them in clinic at 2 to 4 weeks and made a decision after the arterial blood gas. The arterial blood gas had to show persisting hypercapnic respiratory failure. We excluded those patients with obstructive sleep apnea. COPD OSA is a different condition. We were targeting COPD patients. We were targeting 6 COPD patients who are in a recovery phase. They could have been too sick. We may not have seen an effect. And there's definitely no doubt there's very little treatment option available for these folk. So really important that we did this right. Any large trial which is trying to recruit critically ill patients, the screening is going to be a large proportion of your consort. 2,021 patients were screened. This allows me to understand the patients this is going to be effective in. We talk about phenotyping COPD. We've got a phenotype here now, which we can use a treatment potentially which will improve their outcome. 16% of the patients declined. Some of them had BMIs that were elevated with obstructive sleep apnea. Interestingly enough, 26% of the patients had an arterial blood gas that had normalized by 2 to 4 weeks. Really important that we understand that. And the other end of the spectrum is the group of patients who are palliative. They were approaching end-of-life care. 16% of the population was actually discharged on non-invasive ventilation as part of clinical practice, because every time we tried to withdraw the non-invasive ventilation, the patient developed acidemic and acidotic hypercapnic respiratory failure. 50% of the patients that came to see us in clinic had resolved. So those eligible patients had resolved. So it's really important that we enriched our cohort as strongly as possible by taking those patients with hypercapnic respiratory failure. So this was the home oxygen therapy, home mechanical ventilation versus home oxygen therapy, primary outcome, admission-free survival, and the usual follow-up that you'd see with any trial up to a 12-month duration. We wanted to know exacerbation. They all had diaries. We wanted to know effect on gas exchange. I wanted to see a treatment effect. I had to see non-invasive ventilation was working. Because anybody doing trials, when you end up with a trial that doesn't show a difference, you have to understand. We know if we deliver the treatment, we should see an effect. So it's really important that we actually captured all of this data. And obviously health-related quality of life, which is so important. We had a protocol for driving down the carbon dioxide, and that was actually using a protocol that we've developed over many years in the unit where I work. So these are patients who are followed. We use a nurse-led titration protocol to drive down the CO2. You'll hear high intensity, you'll hear high pressure. What we use is more of a high pressure approach. High intensity resolves a high backup. This was an IPAP of 24, an EPAP of 4, a TI of 1, and a backup rate of 14, with 1 litre per minute oxygen therapy entrained. The home oxygen group just had 1 litre per minute. We did get a treatment effect. If you look at the overnight oximetry and transcutaneous CO2, we drove down the carbon dioxide from the starting treatment down to 12 months. The treatment was working. Interesting enough, the arterial blood gases at 6 weeks and 3 months were different between the groups, where the CO2 was driven down in the non-invasive ventilation, the home oxygen, home mechanical ventilation group. However, when we look at 6 months and 12 months, there's a lack of effect. And you have to think to yourself, why is that? Well, in fact, in this trial, and we had this as a safety criteria, if the patient hit the primary endpoint, being in the home oxygen arm, they could then transfer, after discussion between the clinician and the patient, to the treatment arm. So this was really important, that you actually dilute out your effect. You should never do it as a trialist. You should be pure, and you say you don't get the treatment. But we didn't take that approach, which set us up possibly for not seeing an effect. But again, it made it even more important, if we saw an effect, that we took all this into account. So this is the primary outcome. I never get bored at looking at this Kaplan-Meier, and I won't ever get bored of looking at this Kaplan-Meier. In physiological terms, when we started the study, when we understanding how to treat patients using non-invasive ventilation, translating it into a clinical effect is no mean feat. So what does it mean? What does the Kaplan-Meier tell me as a clinician? Well, I'm increasing the time to readmission or death by 90 days. In fact, death was 30% in each group. So in fact, I'm promoting or elongating the time to readmission by 90 days in the treatment group. We're reducing the likelihood of readmission by 50%. So this is absolutely phenomenally important data. It's important data for the patient, because they will have a treatment that will stop them being readmitted into hospital. But it's also important for the payer, because there is now penalties levied on a number of healthcare organisations when you get readmissions within 28 days. So it's really important we can reduce those readmissions. And the 12-month readmission risk or death risk between the groups was 17%. So the absolute risk reduction was 17%. That equates to 6 patients being treated with home oxygen therapy, home mechanical ventilation to prevent 1 readmission. Really important. Could you go back and think about acute non-invasive ventilation? Death is 8 patients, intubation is 6 patients. So this is actually in line with the acute non-invasive ventilation data. What about quality of life? At 6 weeks we saw an improvement, but then we saw no further difference between the groups. And you can split that either way, but there was no detrimental effect on health-related quality of life, which is different from the AVCAL study. Acute exacerbation rate. We actually felt that we may not affect exacerbation rate at all. But in fact, what we found was a reduction in exacerbation rate, because we actually thought the patients might just be at home exacerbating on non-invasive ventilation, but they didn't have to come into the hospital. But we did see a reduction in exacerbation frequency by 1/3. 28-day readmission. We saw a reduction in 28-day readmission by 2/3. This is an important clinical effect. How does it work? So, high CO2 at 2 to 4 weeks. You have chronic respiratory failure. We give patients non-invasive ventilation. That treatment with the HOT-HMV treatment ends up treating the chronic respiratory failure. That reduces the exacerbation frequency, and there's biology to support the reduction in carbon dioxide having an effect to actually reduce infection. Within that, there's a reduction in 28-day readmission. There's an enhanced related quality of life. That's an early effect. And then we've got a reduction in readmission at 1 year. So going back to the mortality in each arm was about 30%. So why didn't we see an effect on mortality? Well, as always with clinical trials, which is the devil within clinical trials, the observational data says 45% mortality at 12 months, and we got 32% in the control arm. People in clinical trials do better. So if an effect is going to happen with a treatment, it has to be a real effect, because the control group are already falsified in terms of their outcome, because they will have a better outcome. Readmission is the early effect. We will have mortality data at 3 and 5 years. Dilution, we were crossing patients over. We were breaking all the rules for clinical trials, but we had to be pragmatic. These are seriously sick patients. What we did, we crossed them over, so we diluted out the effect, but the effect was still there. So despite these breaks in the rules for clinical trialists, we still had a clinical effect of treatment as well. So the change to practice, again, it's getting these patients at 2 to 4 weeks. It's making sure we get them stratified. If their CO2's normalized, great. They don't need to be part of your HMV program. If it's not normalized, they come part of the HMV program. This is actually the slide that we use in order that we can inform our clinicians of what we want them to do for these patients coming through and requiring acute non-invasive ventilation. If you want this, you can Google it, just type in Lane Fox unit and go to the specialities tab, and it's all on there, so you can download it. I'd especially like to thank the people that have been involved. Most importantly, it's the patients. The patients really, really were fabulous for this study. They're very sick, and they really took on board, and some of the patients who have been involved in this study actually got involved in a number of more studies as well. So really important to have that patients that are going to support the work. The HOT-HMV team and the Home Mechanical Ventilation UK network that's now been set up and established in terms of a research network. The King's College London's statistical team, it was actually the MRC that did the intention to treat, but the KCL group have done the per protocol analysis. And then the health economics team, which is Boston Healthcare. This was an independent group that looked at our data. So every bit of analysis here has not been looked at by us until we're presented the report. This is the best way to look at trial data. There's no biasing, there's no changing the data. You know, this is the highest level of interrogation and analysis of data. The funders and the sponsors, without that, we would not have proceeded with this trial. I will say this is possibly the cheapest trial for non-invasive ventilation in history, because it was about £500,000, which sounds a lot, but considering we started the first round table in May 2007 and we published it in June 2017, it's not really that much money overall in terms of the actual events and the effect that we saw. So there's a whole big group. Jill Arbane is our trials coordinator. Without her, we would have never seen the end of the trial. So really important. And I'd like to thank you all for listening.
Thank you very much, Nick. Since Nick needs to leave after his talk, we're going to have the discussion on this talk right now. So anybody who has questions, please come to the microphone, introduce yourself.
Thank you very much, Nick, for this very nice presentation. I have two questions that are one question in two. The first one is, how many patients moved from the non-interventional group to the interventional group? And the second is, if I well understood, you only move patients after the 3rd month. That's okay? So how many patients move? Because this maybe explain the effect, as you said, in which there is a reduction in the, that there is a cutoff at the 3rd month in terms of mortality, because the curve is parallel after that.
Yeah, you're quite right. So it's early event rate. This is all about early event rate. The mortality was picked up. So 29% of people crossed over from the hot arm to and then had HMV added. So there's 29% that crossed over. So really important when you're looking at your data, you take that into account. But the great thing about intention to treat analysis is that, well, it doesn't matter, because you're going to chuck all the data in and the data will tell you what the answer is. And so it's really meant to, or intention to treat is meant to like mimic clinical medicine. That's exactly, some people will use their vent, some people won't, but you have to know there's an effect. So 29% crossed over, and I agree with you, we're seeing early event rates with both readmission and death, as you quite rightly say, from the Kaplan-Meier. And anybody who's looking at Kaplan-Meier plots, it's not just looking at the difference. You want to see when the events are occurring, because that gives you an idea of the clinical condition you're dealing with. And I think for some of these guys, they failed to recover. That is really what we've got. We've got a trajectory of these guys afterwards not really recovering and then actually going into decline. Either they get readmitted or they die.
Okay, thank you.
Thank you.
Thank you. Is the effect mostly in the, it's all in hypercapnic patients few weeks after discharge, 2-3 weeks. Did you look into those who had one exacerbation, or is it mostly in recurrent exacerbators? So if I have a patient that comes out after an exacerbation, hypercapnic few weeks later, had just one exacerbation, would that be a patient that you'd put, or would you wait? Or is the effect mostly in those who are frequent flyers?
Yeah, so it's interesting. Acute non-invasive ventilation is the work of the devil, according to the patients. So, you know, their experience of acute non-invasive ventilation, yes, it saved my life, but blimey, it's a tough thing to have to do. So we had patients coming into the trial who had actually been in for perhaps 1 or 2 rounds of acute non-invasive ventilation before they said, yeah, I'll be in a trial now. So there's a real issue at the moment with our delivery of acute non-invasive ventilation. Yes, we know it's effective, but I think there's other things we need to do so we don't dissuade patients from having long-term non-invasive ventilation. What we did actually, just to bring you actually a point of the groups and making they were balanced, as our minimization criteria, we took a cut-off of more than 3 admissions requiring NIV or not in the previous year. So we wanted the groups balanced. That is imperative for any trial. The last thing you want to do at the end is just go, well, you've seen an effect or not an effect because the groups were not matched. And so we spent a lot of time going through the whole idea of matching. So it was based on your use of long-term oxygen therapy. So we divided the patients up based on that. We took the center effect, multi-center trials. You want to see if there's a center effect. One of those centers may be an outlier. So you have to understand that. And then we took exacerbation frequency. So again, we could see they were matched.
So would you recommend it for somebody who had just one exacerbation, still hypercapnic?
Yeah, absolutely. So we've got patients coming through. So unfortunately, because there's such, you know, we're awash with data, which is brilliant. But you'll see the FEV1, if I hadn't gone so quickly, is 600 mils. You know, these are sick COPD patients.
Nick, I have a question about the quality of life, because if you look at different patient groups, restrictive disorders, and we improve gas exchange, they sleep better, and all have a sort of improved quality of life, which is not the case in this COPD patient. Do we have any explanation for that? Because you have so many positive parameters.
I just think UK people are just moany and a bit... Well, I honestly don't. I've thought this through. I mean, I'm actually going to stand up here and say to people, have you got any thoughts on this? Because I would expect an quality of life effect. We've affected everything else, and quality of life doesn't seem to be affected. So either quality of life is the outlier, or we've got 5 other things that are outlier. I don't think it's the 5 other things that are outlying. And I just wonder if we need, perhaps, for this group of patients that are acute exacerbators, because all the work we've seen from the SRI, from Wolfram, is all stable COPD patients who have got a bit of a headache and feeling a bit sleepy and lethargic, and you give them a ventilator, they're better. We're looking at a group of patients that are really sick, they come in, they nearly die, and then they're meant to be grateful just because they've got an improvement in their carbon dioxide and they're not coming into hospital and they're going to get a change. So I think it's the phenotype of patients we're looking at. We're all talking about phenotypes. This is a very particular type of patient that we've got. Now, interestingly enough, and thank goodness nobody really picked up on it, but I'll pick up on it myself because I've been thinking about it, the EQ5D is different. There's a difference in EQ5D between the groups. Now, EQ5D is the most blunt tool you can use. So it's bizarre that we're picking up. And what I haven't done is gone through the EQ5D and see where which domains are different. Because I think you're going to find it's a domain effect and there's going to be some kind of real powerful signal. And then we can start looking, because if it is a domain effect, then we look at that domain within EQ5D. So I think there's stuff that we can now do to come up with quality of life questionnaires, not for stable, not for settled type patients, but for these post-exacerbation acute patients. I'm glad I taught that through because I think that's a better answer.
I would also have a comment. Nick, if I look at your screening chart, which is very interesting, you could think that out of 2,000 patients, just 100 end up on NIV, which is, you could say, well, that's a small group. You know, I just need a small service. If I look at your screening chart, more than double the patients that were not in the trial were not be able to be weaned from NIV. There is, I think, 4% who have sleep disorder breathing. There is an obesity group, and there is another group. So if I just did a back of an envelope calculation, so that means that rather every fourth patient who's in your screening log would end up clinically on an NIV.
Yeah.
Is that also your experience, that you've got a tight population here in your trial, but in clinical practice, the population is much bigger?
So we're being a bit more all-encompassing for our clinic. So we want the obese patient after they come through the ICU. I don't know if you've ever looked at your ICU data. If you look to see how many people are hypercapnic when they come out of ICU with obesity, there's more than you possibly imagine. We're capturing all of those into the clinic as well. So, you know, we've made it a much more structured approach. It's not just about HOT-HMV, it's about the the post-chronic or the post-acute respiratory failure in the obese as well. So we're putting them all together. As it goes for COPD, we're running the clinic because on the amount of patients coming through, and it's really important for everyone to know. So we run the clinic, so it's actually Patrick Murphy and Isik Su that are running the clinics, and they're doing 2 each a month, so we're doing 1 a week. And we're picking up 1 or 2 patients. Now, we cannot get the patients in quick enough, okay? I don't know, it's a real tough. We're actually setting them up in clinic, because not as a ultimate titration of the patient, but at least to get them on the ventilator when we see them in clinic. And then what we will do, because we know you're going to end up on 24/4 with a TIF1 and BACA rate of 14, taking the group as a whole, but we're probably sending them home with 18 or 20 centimetres, and then they're coming back in 2 to 4 weeks, which is when we've got an admission, and they get a titration optimization. So we're taking a very pragmatic, you take your clinical data and you make it work for your service, because we couldn't say, right, we need to admit everybody, because it just would not happen.
And the other question is, do we really need to wait 2 to 4 weeks? Or can you predict from your data who's going to stay hypercapnic?
So Peter and I are best friends anyway, but so Rescue was actually the pre-runner to HOT, and you know, it's just, we learnt a lot from all the studies we've done. We're doing an observational looking at bicarbonate levels and basic cess to see whether we can predict hypercapnic respiratory failure at 2 to 4 weeks. So if we can predict a CO2 greater than 7 or 50 millimetres of mercury, then we have prediction modelling. And then what we're going to do is drop it into the rescue cohort, and hey, presto, we've got the easiest way to prove what we've done. So you need to have observational and then a validation cohort, and then we'll be fine. And then you'll be able to say, oh look, their bicarb's 32, bicarb's 28, whatever the number is we come up with, and you'll know, well, their CO2 is going to be higher 2 to 4 weeks, send them home with non-invasive ventilation, and then get them back as an inpatient in 4 weeks to titrate. You know, there will be modifications with all this data.
I mean, the other point, as you said, a lot of your patients don't like the acute intervention, which saves their life. There might also be a benefit in sending them 2 weeks home and kind of like getting some wellness time off the ventilator before being put on again.
And the importance of it as clinicians, because you're all walking around, you're seeing these guys and you're worried about them dying. Well, do you know what? I think it was 1 out, even on the screening log and everything. The event rate of being readmitted in crisis was very low. The first patient we set up, I know the first patient we set up, you never forget the first patient, who had a pH of 7.32. So, you know, it's kind of, you know, it was, because we used 7.30 as the cutoff because we want to make sure we had an enriched population. So when we set that patient up, he had a pH of 7.32 and he got randomized to oxygen. And I can't tell you how worried I was. And as the trial went on, and it went on and on, as the trial went on, I got much more confident with these patients not destabilizing. And that's really important. You know, we sit here as, you know, and talk about trials, and they can be, you know, people do them in a really bland way. I want to do it as a clinician. I want to tell you what it helped me understand about these very, very sick patients.
Great. No more questions, Nick. Thank you very much.